Welcome to the Westport Library. Today's program will begin momentarily. Supported by Verso Studios, created locally and shared with the world.
Good evening. Louder. Yeah, I know you just came here because the air conditioning is free. True dat. So I'm Andrew Wilk. I'm a very proud trustee of this wonderful library, and a warm welcome to my fellow Westporters and from all parts hither and yon. Are you just here because, like me, you're a little bit neurotic and this is a topic that is near and dear to your heart and very, very fearful? Well, I know that's why I'm here. That's why we did the series, right, Bob? This and more. So tonight is part one of our three-part series on the brain. This is a continuing opportunity for our community to learn about some of the most important medical issues of our day. Each of our three-part discussions on the brain will provide a general review as well as state-of-the-art updates on common neurological problems. Dr. Robert Altbaum, a longtime Westport internist, will once again moderate these three sessions, which will feature a neurological specialist who will provide an overview of the evening's topic and also highlight the newest medications and technologies available. This evening's guest speaker is Dr. Daryl Story. He's a neurologist with a subspecialty in cerebrovascular disease, if I have that right. Dr. Story examines strokes and transient ischemic attacks, or TIAs. He'll review the presentation, management, and new technologies used to treat this potentially devastating disease. So just to look ahead, on October 30th, we'll look at understanding the most common neurological problem that we pretty much all have, headaches. We all get them, but what can we do to prevent them and treat them? When should we worry that a headache represents perhaps something more dangerous? For that episode, we'll be joined by Dr. Daryl Story, a neurologist and headache specialist who will discuss the causes of various types of headaches so we can better understand diagnosis and focus on the newest therapies in tension and migraine management. Then, and on October 21st, Dr. Michael Fitzpatrick will be discussing the very real fear of dementia and potential reversible causes of the disease. Dr. Fitzpatrick will further explore the physiology of dementia, its current treatment, and shed some light on some of the controversial new therapies that have recently been approved by the FDA. Dr. Altbaum is the host of our continuing medical series. He received his medical degree from Harvard Medical School and continued his training at Mass General and Yale Hospital. Dr. Altbaum will tell you more about Dr. Story in a moment. But my thanks to Dr. Story and Altbaum for being here, and Bob, it's all yours. Thanks.
Thank you, Andrew. Thank you all for coming tonight to the Westport Medical Library Series, conceived of by Andrew Wilk and supported by the library. We've basically done cardiology. We did 3 series on cardiology, and now we're moving on to neurology. And we hope that if people are interested, we're going to just cycle through all the major subspecialties, and then we'll cycle back. There's an awful lot to learn in medicine. I did want to introduce Dr. Story a little bit more detailed. He is a senior neurologist at Neurology Associates of Norwalk. He went to Dartmouth undergraduate and then New York Medical College, completed his residency, medical residency, and neurology residency at Yale. And if that wasn't enough, he did another year of neurovascular disease. So I think he is more than qualified to talk to us about cerebrovascular disease. So what is a stroke? And I like to think of a stroke as your brain having a heart attack. It's basically a sudden disruption of blood flow to the brain that causes damage to the brain. It can occur because of a blockage in a blood vessel, which prevents the blood from getting downstream to the brain, and that would be called an ischemic stroke. Or it can be due to a blood vessel bursting and basically pushing blood into the brain and disrupting the structure of the blood. And that's called a hemorrhagic stroke. The difference between the two is kind of an analogy to a computer. If you have a computer with chips and you pull the plug, that's like having a blockage. That's an ischemic stroke. It's not getting the electricity, the nourishment to the computer doesn't work. On the other hand, a hemorrhagic stroke would be more like you reached into the computer hard drive and just jumbled things up. But again, the end result is the same. It doesn't work. So as the stroke implies, just the name says it's something sudden, sounds emergent, and obviously one other thing which is important is that time is brain. We really want to act quickly to save the brain. So we try to do anything we can to salvage brain, and that's a very important concept in stroke. Now, as I mentioned, there are two types of stroke. There's the ischemic stroke, which is a clot, and that can occur for a number of different reasons. But basically, blood doesn't get downstream, and the brain undergoes cell death. It dies. That can occur because of a clot forming on a blood vessel in the brain, let's say on a plaque of cholesterol. You may have heard of atherosclerosis. Well, a clot forms, and that causes a thrombosis. Or a clot can form elsewhere. It can form deeper or lower down in the vascular system, or even in the heart. And it breaks off, and then it goes to the brain. And that's called an embolism. And if it occurs in the artery, we call it an atheroembolism. And if it occurs in the heart, it's called a cardioembolism. You may have remembered we had a talk on atrial fibrillation, and that's a very common cause of cardioembolism. The important fact is there are many causes that can cause strokes, that can cause ischemic strokes. There are a myriad of other causes, but again, thrombosis, atheroembolism, and cardioembolism make up the majority. The brain has a pretty complicated blood supply. This is a real simplistic cartoon, but basically you have two carotid arteries. Those are the two arteries you always feel in the front, and that goes to the brain in the front. And then there's two arteries that go up the back of the neck called vertebral arteries, and these feed the back of the brain predominantly. But they don't look as simple as that. This is even a simple cartoon still. It kind of arborizes like a tree. Each blood vessel arborizes like a tree. And what happens is when one of these branches gets a clot, the tissue downstream over here will die. And that's basically what an ischemic stroke is. Now, one thing that's fortunate for all of us is that ischemic strokes aren't necessarily all or nothing. And here's, again, what can happen. This is the normal vessel that's feeding this area of the brain. If this clot occurs, there's death of tissue or an infarct. Fortunately, very frequently, blood supply comes from other vessels that surround that tissue as well. So it goes around kind of a detour. We call that collateralization. And that enables us not to always have a severe stroke in the setting of a blood clot. And here's a good example of what happens. Here's the clot. This area of the brain dies irreversibly. That's dead. But some blood flow is coming down through collateralization, and it creates this circle called the penumbra. That tissue is really very important because the penumbra of tissue is what's potentially salvageable. All the things we do, these, the clot busters, going in and pulling out clots, that's not going to save this. This is dead. But it may save some of the penumbra, and that's really what we're trying to do. Hemorrhagic strokes are a different kettle of fish completely, and I don't want to get into them too much because they only make up about 15% of strokes. 85% of strokes are ischemic strokes, blood clot, blockage strokes. But these come in two flavors. They come in the blood that goes into the brain tissue itself. We call that an intracerebral or intraparenchymal stroke. And then sometimes it can bleed around the fluid around the brain, and that's called a subarachnoid stroke. Now, the brain is, again, a very interesting structure. It's not just random tissue. The brain is very compartmentalized in its function. Areas of the brain do different things from other areas of the brain. There's an area that's for vision. There's an area for hearing, an area for speech, an area for movement. So based on what blood vessel to what area is damaged or clotted, that area is going to die, and that's the function you may lose. So the question is, how do you assess this? Well, probably the best mnemonic I've heard, and a mnemonic I'm sure you've all heard for this, is the term be fast. And be fast is a very nice way of describing the different manifestations of stroke. I like the term because it really accentuates the speed. It happens suddenly, you have to act quickly. The B stands for balance. The E stands for vision loss, a sudden loss in vision. The F stands for face, a sudden facial droop. The A stands for arm or leg, and that could be a loss of sensation or a loss of strength. And the S stands for speech. It could be a slurred speech or even an inability to understand speech. But those are the common things that you would see that might make you think, oh my God, it's happened suddenly. It's a neurological abnormality. He may or she may be having a stroke. Now, there are obviously a lot of other aspects of strokes. You can have a terrible headache. You can have coma. You can have a seizure. But these are really practical ways for the lay people, at least, to think about stroke. Now, why do we care about stroke? Well, we'll just let that on the floor. Why do we care about stroke? We care about stroke because it's really common. 800,000 people in the United States have a stroke annually. And of those 800,000, 130,000 die. And that's really not necessarily even the worst part of it. There are 670,000 people that could be disabled or have a major change in the quality of their life. And that's really what we're always trying to do, is minimize the damage done by that. Also importantly, and not surprisingly, based on that compartmentalization, you could have a small stroke in an area and you may have a slight loss of hearing. You could have another stroke in a small area and you can't speak. So strokes are not just how much territory or how much brain is damaged, but where it occurs. And therefore, you really have to quantify functional deficits of a stroke. And the best way to do that, or the common way to do that, is a term called the NIH stroke scale. Basically, it allows doctors to talk about the severity and talk about the functional deficits, so you can use that for things like studies to see if a person's getting better or worse. It's a commonly used term. I don't want to really belabor this. This is kind of what it looks like. It's just a point scale. You don't have to remember it. No one's going to be tested. But it's a practical way of conversing among doctors. Another thing that's important is not all things that look like a stroke are a stroke. You'd think, well, person can't move his right leg. Maybe it's a stroke. Well, it could also be, believe it or not, a migraine, or it could be a seizure, or it could be multiple sclerosis. So one of the things the doctor has to do, in addition to deciding if a sudden change is a stroke, is it a stroke, or is it a stroke mimic? This is a common list. This one some of you may have experienced, Bell's palsy, a facial droop. There are ways of telling whether it's a stroke or not. It can be very frightening. People walk into your office convinced they have a stroke. There's a sister to strokes. It's really, or a cousin, but it's basically a term which you may have heard of called a transient ischemic attack, or TIA. A TIA behaves and looks like a stroke. It's only of the ischemic type, not the hemorrhagic type, where there's a blockage of a blood vessel and there's a sudden functional loss of neurological ability. However, it goes away. It's reversible. And strokes tend not to fully reverse. Now, we used to think a TIA, or a transient ischemic attack, was simply a neurological symptom that was caused by a blood vessel problem that went away and was fully reversible. And then we got MRIs, and we realized when you do an MRI of these people, up to 40% of them actually had small strokes. So we've changed the definition of a transient ischemic attack to basically a vascular phenomenon that causes a neurological loss that fully reverses, but it has to have a normal MRI. And that's a very important concept. This is just kind of a visualization of the clot. And obviously some clots just break up. They dissolve, they fragment, and the blood supply is restored. And that's really why it reverses. The clot doesn't stay there. It just dissolves. The body has mechanisms to dissolve clots, or the clot, as I said, may be fragmented, break apart, become very small, and then the neurologic event reverses. If it happens quickly, you may have no evidence of neurologic damage and no evidence of damage on an MRI. Why do we even care about strokes? Well, this is the reason. Stroke, a TIA, is a warning sign for a future stroke. And actually, when I see a TIA, I think just as emergency as is a stroke, because this person really has salvageable tissue. This is a good thing. He or she is having a neurological event that if we don't address it quickly, there's a 20% chance within 90 days that that's going to go on to a permanent stroke. And half of that risk, 10%, is in the first 48 hours. So somebody comes in, they can't move their right side for 20 minutes and it goes away. Don't say, oh, it's gone. Say just the opposite. We really have to look very quickly and intervene, maybe admit them to the hospital, which is often does, to look at the mechanism. Is this a cardioembolism? Is this a atheroembolism? Is this a thrombosis? Is this a narrow blood vessel? Because once we can figure out the mechanism, we hopefully can prevent a future stroke downstream. Very important concept. Just like strokes, not everything that looks like a transient ischemic attack is a transient ischemic attack. Migraines, seizures, blackouts, even hypoglycemia on rare occasions, demyelinating disease, they can all look like a TIA. I must say, Mitch McConnell kind of brought this all into the news recently. Mitch McConnell's having, I think he's having seizures, but he's having these spells in front of everybody. And they're saying, is this a mini stroke? Is this, or the nonsense that he's dehydrated? I think that's a little ridiculous. But something is happening to this man. It looks mostly like a seizure, a non-convulsive seizure. But these are things that can look just like TIAs. Again, the challenge for somebody like Dr. Story is to not only say, is it a TIA, but also to make sure it's nothing else, because the treatments are radically different. Very important concept. So what do we do in the setting of a person who comes in with the stroke? It happens very quickly. We want to make the diagnosis of a stroke. We certainly want to rule out the things that can mimic a stroke. That there's a long list, but you get good at it. You get a CAT scan because a hemorrhagic stroke shows bleeding in the brain, very easy, and it's treated totally different from an ischemic stroke, which shows no blood flow or decreased blood flow to the brain. Very different treatments, so you have to know very early on. And then you want to assess the damage. You do that by the NIH stroke scale and by taking pictures. All of this happens very, very quickly. And while it's happening, we're really doing two things simultaneously. We're treating the patient and we're trying to diagnose the cause of the patient, the cause of the problem, the mechanism. So we're treating the patient simultaneously, but we have to stabilize the patient. Maybe the patient's in a coma. Maybe they can't breathe. Maybe they can't swallow. Have to stabilize them. Then you want to decide, and Dr. Story will go into this much more detail, whether you need to do an immediate intervention to open up that blood vessel, whether the brain is still salvageable, because that's really why we say time is brain. You've only got a few hours to make this decision and make the correct decision. You obviously want to decide for future events what caused it, because if it's an atrial fibrillation causing a cardioembolism, you're going to put the patient on anticoagulants to prevent it. If it's a small plaque, you may put them on aspirin or something simple like that. A lot of different causes. You also want to address the severity of it, or the causes of the atherosclerosis. And the thing that used to be the treatment, which is all I really had to do when I started residency, was you supported them. You had a stroke. I'm sorry, we can't do anything about it. It's done. And then you basically gave them physical therapy, and speech therapy. We have come a long way from that, as you will hear, a long way. Lastly, we have to evaluate the patient. What caused the stroke? And I like to think of the system as a closed system. You have a heart, you have blood vessels down here that go to blood vessels to the brain, and you have a brain. So you have to assess every one of those when it comes to a stroke. How do you look at the brain? You look at the brain with the CAT scan or an MRI. You can assess this, whether it's ischemic, hemorrhagic, the severity of it, and there are lots of remarkable MRIs that can even tell you what's salvageable and not salvageable. You have to look at the blood vessels. And the reason you have to look at the blood vessels is because the blood vessels may be narrowed. You want to see where the blockage is if you're going to go pull out a clot. So you might do an angiogram. There are two types, a CAT scan angiogram and an MRI angiogram. But those will look at the blood vessels. You want to look at the heart because the heart could be the source of an embolus. So you might do an echocardiogram to look at the structure. You might do a cardiogram. And if you remember the atrial fibrillation talk, for those who were here, atrial fibrillation can cause clots that break off from the heart and go to the brain. So you might even do a long, prolonged monitor of the heart rhythm to see if these people are having silent atrial fibrillation that's causing clots. And finally, something that kind of is intuitive, there's blood. So you look at the blood, you do a blood count, make sure the blood isn't too thick, too thin. You would check cholesterol, check diabetes. And this is kind of a simple table that kind of summarizes each system and what you would do for it. So that's where we are today in terms of simple treatment, very overview, obviously evaluation of it. And then finally, what's happening now is we are a long ways from just giving support. We have a lot of things we can do quickly that can really reverse some of the damage done. And I'm going to turn the podium over to Daryl Story.
Thanks, Bob. Thanks for the kind introduction earlier. And thanks to you and the organizers for inviting me to speak tonight. And I'll just say, like I've said for much of my career, it's hard to follow Bob Altbaum. And that goes back to all the years that I saw patients in the office that were seeing Dr. Altbaum. There was usually nothing left to add. You know, he sort of really covered the bases. He knew neurology as well as he knew internal medicine, and it was either that, it was going to be a straightforward, I agree with Bob, or it was going to be a tough head scratcher, because if it stumped Bob, it was going to likely stump me. And I think my partner, my former partner, Bob Levine in the back there, my dear neurology partner, would probably say the same thing. I need to get my slides on here. Let me see if I can do that. Okay, I think I go here, and excuse me for a moment. There's the start this slideshow. Okay, is that there? All right. So I'm going to skip over a couple of slides because it's really duplicating what Dr. Altbaum has mentioned. But again, what is a stroke? Again, it's a disruption of the blood flow. So both ischemic and hemorrhagic have the word heme in it. So it's problems with blood, right? So heme comes from the Greek and it indicates blood. So it's a problem with the blood supply to the brain, whether it's a rupture of an artery or a blockage of an artery. And again, we've seen this information already. This is my version of the anatomical relationship of the blood vessels that go up to the brain. So I think is this pointer working? Yeah. So the vertebral arteries in the back here, amazing anatomy that the vertebral arteries manage to thread themselves through these what's called transverse processes, these bony wings on the side of the vertebral bones there, and keep them protected in the back part of the brain there. Amazing anatomy, and the carotid arteries in the front. So the two posterior circulation and the anterior circulation, we call the back and the front, they meet up in the base of the brain there and really provide some nice redundancy in the blood flow, and it helps out in some of the issues that Bob brought up, which is that sometimes you can have a stroke symptom for quite a while and still have some hope for replenishing blood flow to parts of the brain that may just be threatened and not already lost. So that's a basic schematic of what that looks like. And this is one of my favorite slides that I've shown for a lot of years. It's fairly simplistic. But it breaks down stroke into, I think we can talk about stroke as a number of different diseases. It's heart disease, it's cardiac disease, right? So the pump, right, is sending blood out to the body and up into the brain. So anytime blood is not continuously moving, if it's stuck somewhere, it gets burrowed into the nooks and crannies of the heart somewhere, it starts to clot. Blood does not like to sit still. If it's sitting still, it clots, and that's where these problems come from in the heart. So in rare cases, that can happen down in the muscular part of the heart, say after a heart attack or something, where the muscle isn't squeezing properly. And it can also happen in the atria. So we all recognize, or many recognize, atrial fibrillation. And so in AFib, the atria are not coordinating with the ventricles and beating in a coordinated way to keep the blood flowing, and it just fibrillates or sort of quivers there. So the blood gets stuck in those areas and then breaks loose and travels out to the body or up into the brain. And then you have sort of traditional athero, right? Traditional atherosclerosis. It's the #1 killer, right? So it affects the large arteries all over the body. It affects the aorta. It affects the carotid arteries. It can affect the vertebral arteries. It can affect the larger arteries inside the brain. So you can have atherosclerotic buildup of cholesterol inside the arteries in the brain that can eventually lead to trouble. We all know it's the same process that's happening all over the body. The aorta, the renal arteries, the arteries in the legs, and of course the coronary arteries. It's all the same process. It's all similar risk factors that causes over the course of years of human existence buildup of cholesterol in the arteries pretty much all over. So, and that's a major cause of stroke. And then in the brain, there's something that's kind of particular. On this slide, it's mentioned as penetrating artery disease, and that's either microvascular disease or small vessel disease. There's something kind of unusual about the brain circulation. It also happens a little bit in the kidneys, but there aren't many places in which a big muscular high pressure artery gives rise to right angle branches, 90-degree angle branches that come out of that large artery and go and penetrate into very important parts of the brain. This is the MCA artery. It's a major artery. We're going to show pictures of that going forward in this talk. It comes up over and over again. It's the major, big problem vessel that causes a lot of strokes. But off of the beginning of that artery, there's these little branches that come off and goes to very important parts of the brain. So if you lost this little artery right here, and it's in this place called the internal capsule, that cuts off a large part of the cortex of the brain that is providing motor information to the opposite side of the body. So you can have a tiny stroke from loss of a tiny little artery in that location and have a major impact from that. A major weakness on one side of the body. And that's obviously very, very problematic, even though it's a very, very, very small region of injury. Amazing. And this picture doesn't even do it justice. And I'm going to start using the word hypertension and high blood pressure. Can you imagine what these little wispy blood vessels are being exposed to? This is a slice of the brain from a pathological slice that's stained to look at the blood flow and look at the blood vessels. This is an example called the basilar artery. It's similar to that MCA I showed you before, but it shows you how small and wispy those little arteries are that come off of that big blood vessel that's full of systemic pressure, right? That vessel has nearly the same blood pressure as what's in your arm. And as Dr. Altbaum mentioned before, in most places in the body, including most places in the brain, the blood vessels are arborized. That means they go from smaller to smaller to smaller to smaller to very small vessels. In the brain, in some places, that doesn't happen. They go from fairly large vessels to very small vessels. And so just to jump ahead to risk factors, and it can't be stated enough, really, that the number one risk factor for stroke is hypertension, high blood pressure, right? Because what happens to these blood vessels when they're exposed to high blood pressure? My old mentor at Yale said it was like you took the water main coming into New Haven and you attached a garden hose to it. How long would that garden hose withstand the pressure in that water main? That's a little extreme an example, but these little blood vessels either wear out over time, they grow to match the strength of the vessel that's feeding it, and if it grows thick enough, just blood can no longer flow in there anymore, and it causes a stroke one day. But what else would you imagine would happen? A hemorrhage, right? They give up. They say, I can't take it anymore. I've had this pressure for so long, I have to just rupture. So this is a drawing of what an intracerebral hemorrhage would look like from those very same arteries I was talking about, the lenticulostriate arteries, those little right angle branch, tiny arteries. This is what it would look like on an autopsy of a brain. It's just a collection of blood right in that area. This is what a CAT scan would look like, or this is what we see on CAT scans when we image a hemorrhage. It's this big, awful white patch that indicates blood is seeped into that part of the brain and disrupt that tissue and caused a lot of pressure to build up in that area. You can have hemorrhages in other locations as well. But just to drive home one of the first points is that blood pressure, if one message gets through is how do you prevent stroke, it's really blood pressure is like really a very, very major risk factor. And then blood pressure can lead to atrial fibrillation, it can lead to MI, it can lead to cholesterol buildup, it can just promote all of these conditions that we all have to be aware of as humans. So I'm going to show you some slides as we go forward. I'm going to do a couple of brief case reports so you can get some idea about what we do. This is a normal head CT, and it's not as many slices as we look at. We look at probably 30 or so slices to get through the whole brain. But the brain is shades of gray. There's some hollow places inside the brain here that are dark colored. That's where the fluid is, that cerebrospinal fluid. The white on the outside is the bone. And so this just to orient you a little bit. I know probably not a lot of radiologists in the audience. Any radiologists here? If so, you can probably correct me as we move along. But this is what a normal brain scan looks like. This is another example of a hemorrhage, right? Ugly looking, big blob of white discoloration that represents blood that's seeped into that part of the brain. It's also in some of the hollow places of the brain too, here in the ventricles. So this is a person who's had a very devastating hemorrhage into the brain. And where's it coming from? Those same blood vessels I just showed you that are so wispy and sort of exposed to the blood pressure of the years going by. To even go back, so this person with this CAT scan could actually have a stroke. A CAT scan is very good to do right away. We do a CAT scan right away. We can see blood right away. We can see major things right away. But if someone's having a small stroke and they're having symptoms of a stroke, we just may not see it. It doesn't show up right away, and it may be too small to really show through. So what do we use? MRI. So this is a great technology. This is called a diffusion-weighted image. It means that it's imaging acutely injured cells. And so this person has a stroke. And you can see it. It's the little white patches along the brain there. We would not have seen that on a CAT scan, but we can see it very clearly on an MRI scan. And it's here on the, actually on the left side of the brain. The convention for radiology is right is left and left is right. So this person with some injury on the left side of the brain may have some weakness on the right side based on where the stroke is located. So we would use MRI all the time, but it takes longer. It takes at least a half an hour. We need to treat people very quickly, so we just need to get CAT scan data when they roll in the door. An MRI can't be done in many older pacemakers. It can't be done if there's other metal in the body and if you're claustrophobic. And so there's a lot of reasons we don't just use this seemingly better technology. But it does obviously play a large role in what we do. So let's move on to what can we do about stroke. This is fortunately the briefest case report that I've got. It was a lady that I saw shortly after I came to Norwalk about 20 years ago. She came in within an hour. She was out in public somewhere and suddenly was unable to speak properly and had some weakness on the right side. And she got to the hospital very, very quickly. We don't always see this, but this is that same blood vessel I was showing you before. And you see that little white dot? So that's a thrombus in her vessel. So she had a blocked artery here. We could actually see it. We often can't, but it's there. Otherwise, her brain scan looked normal. So she was very weak and she could not talk. But she was eligible for the clot buster. So you've probably heard of TPA or the clot buster medication. This has been on the scene now for 30 years or more as a way that we can treat ischemic stroke if we catch it quickly. And so she got TPA, and by the next day, that little spot in her artery, I realize it's tiny, it's very, very small, it's gone, and she was fine. So she just right there in the emergency department, that little thrombus was melted by that TPA, and she just did fantastic. So that's the end of that case report. A very happy ending right there in the emergency department. But just to briefly go, this is a slide I show doctors, and I don't really want you to harp on this, but really the money is, why does this TPA work? This was published in 1995. TPA was put on the market after this big study was done, and it basically showed that if you had a serious stroke and you got nothing, there was 26% chance that you would walk away from that 3 months later doing very well, like really having no major deficit, believe it or not. But the chances of you having no major deficit with TPA was 39%. So you bought 13%. Gain. So it's not a panacea, right? I mean, it's 13%. We use what we call number needed to treat, which is a way to think about how many people do we have to expose to this to guarantee someone will benefit from it. And if you take the math as you take the reciprocal of 13, and that's somewhere around 7 or 8. So you treat 8 people to get 1 person to really respond to the treatment. But TPA is fraud. I mean, it's been a big issue for all of us for a long time. I don't expect anyone to read this. I can't read it either. This is the playbook for TPA. This is what the doctors have to go through when they're examining a patient who rolls in from the emergency, from the EMS with stroke symptoms. The green is what you must have to be eligible for TPA. The red is what you cannot have. And all of the orange sections here are the relative contraindications, the things that you need to really kind of think about, because it's not a benign medicine. And that's what really limits the use of TPA. It has to be given quickly, and it has to be given to the right person. So it is complicated. So in the emergency department, it's a team of professionals that jump on the case right away. They go to the triage desk if they haven't gone through EMS, and they're coming straight to the emergency department. An alert is called that goes out to all the necessary people, including radiology and such. A doctor evaluates them right away. A CT scan is done to make sure it's nothing like a growth or a bleeding or something like that. The CT gets read, there's a final determination by going through all of that checklist, and then the drug is given. So this involves nursing, it involves an emergency department doctor, it involves a neurologist who may be there in the hospital and running right down from upstairs, or it may involve a teleradiologist after hours or in the middle of the night when there's not a neurologist right there in the hospital. So sometimes it's done via a video screen. It involves a radiologist. So it involves at least 3 doctors and at least 2 or 3 nurses and X-ray techs and CT techs and a lot of orchestration to get this done. And we try to get it done at ASAP, and our internal target is 45 minutes. So it's a lot to get accomplished to try to get this medication into people. So what's the problem with TPA? Well, it's a powerful lysis of clot. It breaks up clot, and it can go too far, and it can cause hemorrhaging. So this would be the feared complication of TPA. This brain scan would be someone who probably had a stroke a few days ago, who may have gotten TPA. The clot was too big, the TPA didn't help. They have all this large shadow of injured tissue here, and you can see it here, a very large stroke, unfortunate situation. And not only that, but bleeding inside the brain. So there's secondarily blood seeping into the space, which can be promoted by the TPA. So this is why it's a challenging issue and a challenging problem, and we've been working on it for many years. The risk of having bleeding that makes you worse is a few percent after all these years we've gotten used to using the medication. So it's fairly significant. So we have to be very, very careful about who gets TPA. But for the next few slides, what else is exciting going on? For what can we do for people who are having an acute stroke right away? So again, this is a slide that I show doctors and residents. But when TPA came on the scene, we could treat people out to 3 hours. This graph here is like how long it's been that you've been having stroke symptoms. So it goes from 0 hours to 24 hours. The longer you go with a stroke, the less likely you're still going to have brain tissue that can be salvaged and that you can recover from. So within 3 hours, and then some additional data showed up to 4.5 hours, we can give IV TPA. After that, IV TPA is just not safe. The brain is too injured, it's too soft, it is much more likely to bleed if you give TPA after 4.5 hours. So if you miss the 4.5 hour window, TPA is out, but we go on to the newer technologies that have now been around for about 8 years called endovascular treatment, otherwise known as mechanical thrombectomy. So this is the new technology that is kind of revolutionized what we can do for people, and it's extended our ability to treat strokes initially out to 6 hours with a device that actually goes up into the brain and pulls out clot. And then after some additional research, it was shown that you can do some even more fancy imaging to determine someone who could have even had a stroke 20 hours ago or 22 hours ago, or more commonly 12 or 14 hours ago. You can treat them way out to 24 hours if they meet certain criteria with very good collateral blood flow protecting enough of the brain so that there's something to salvage. So let's look at that a little bit. Now, as you can imagine, you can't put a catheter that you can actually see and hold into the brain circulation except for large arteries in the brain. So here we are back to this MCA artery that I showed you before, a source of a lot of trouble, a lot of thrombi, a lot of emboli, a lot of debris that comes out of the heart or out of the aorta or other places goes to the MCA. It receives most of the blood flow into the brain, so it attracts all the debris, and that's where a lot of strokes happen. So this is where this technology is really focused on. So if you have a clot that's, say, in this area here, it implies a lot of injury to the brain, all distal to that, and that's exactly where a neurosurgeon can put a device to try to remove that clot mechanically. Now, if they're within 4.5 hours, we also give them TPA, and if it works, great. But in these large vessel occlusions here, it may not be enough to really dig out that clot, and they need something mechanical. If it's after 4.5 hours, they're no longer eligible for IV TPA, and they can only get this mechanical means of trying to open up that blood vessel. So this is kind of what it looks like. The original technology was these, it's called retrievable stents. So you would thread this stent device up into that clot there, burrow through the clot with a small catheter, deploy that stent. It would sort of trap the clot within the stent, and then you could just pull the whole thing out and just physically remove that clot, which is quite amazing. So the technology has gotten to the point where you can build materials that small and that easily navigated up through the body and up into the brain, and that's how we've gotten to where we are with this, which is really fantastic. Again, so this is a similar scan where you can see there's a blockage here, and then this is a person who's got a bad stroke, and if you can't unblock that artery in time, this is what that stroke might look like. A lot of darkened, lost brain tissue here on that side of the brain. So here's a case that we saw a little bit ago. A 75-year-old gentleman who had been having a series of TIAs. So a TIA is a warning, right? So he had been having a series of TIAs. We kept on increasing his antiplatelet medications. He was on aspirin, he was on Plavix, he was on, which is otherwise known as clopidogrel. And yet he still came in with this event. He did not have atrial fibrillation. We tried and tried and tried to find that, did not have it. Did not have any blockages in the carotid arteries that needed any attention. But here he comes with 10 hours after he onset with these symptoms of weakness and difficulty speaking. So go back to our little timeline here. Here's where he falls. He falls at 10 hours out. So we can say, well, there's no possibility to give IV TPA. He's too late for that. But he's able to get a mechanical treatment. But as I mentioned, we need to do some more studies. First, we need to know, is there a vessel that's large enough to get a device into? So that's what comes next. And here's what his scan looked like. This is a CTA or CT angiogram. And you can see on this side, the good side, there's flow through this artery that goes all the way out, and it sort of keeps going, and that's very nice. Over here, it just comes to an abrupt end, right? So that was his problem. He had what we call a large vessel occlusion, or LVO, and so this gets everyone kind of worked up that it's time to call the surgeons and try to get the team in and get this treated. So, but it's 10 hours, right? There were some actually subtle changes on that CAT scan already showing. So after 6 hours, we need to go beyond this study. We need to say, well, is there anything left to salvage? And that kind of looks like this. Dr. Altbaum already brought up what we call the core and the penumbra. So if you block this artery, the dark pink might be tissue that's lost and not retrievable, not salvageable, but the light pink here might be tissue that's just sort of not functioning, but able to be livened up again and salvaged if the blood flow can be restored. So if only we could measure that. So the technology keeps advancing. We can actually measure that. So this is another CAT scan. It's called a CT perfusion. And this basically looks for either no flow, like regions of brain without any blood in it, versus sluggish flow, so slow flow. So they call this core to penumbra mismatch. And the incredible computer algorithms that analyze these studies, basically you give a shot of contrast, and then the CAT scanner takes so many images at such a rapid pace, it can follow the blood with the contrast in it seeping into the brain. And it can measure how long it took to get there, how long it stayed there, how long it took to exit, and where were places that just didn't have much flow at all. And so then you can process all of these images in a computer, and you can come up with a simple looking picture, which means that pink is lost tissue, and green is salvageable tissue. So if the green is significantly bigger than the pink, then you're good to go. You can actually do a thrombectomy and hope to make a difference for that person at an extended hour after the onset of the symptoms. And so this person actually did have the procedure done. This is an arteriogram, so now the surgeons take that person to the lab and they thread a catheter through the groin and up into the brain vessels. And this is what that looked like before treatment and what it looked like after treatment. So the blood flow is restored, and the person actually did very well. Now I was concerned about this, and I am right. Oh, maybe it'll work. Yeah, it's actually going to work. Yeah. Oh, if that's too loud, sorry, I didn't warn the. I didn't warn anyone for sound, but this is a newer device. I showed you before the stent retriever. So that technology is still used. The little stent that goes in and pulls a clot out via this retractable stent. But this is a newer technology by this Penumbra company, which has come on the scene and has been shown to have similar benefit and a little more ease of use than the stent. So this is kind of what happens. This is a video that's by the company, just in full disclosure. This is Penumbra's video on YouTube to advertise their device. I have no stock in Penumbra. Actually, I'll show you that in a moment. And I'm not here to advertise this company at all. But the technology is amazing. So this is vacuuming in the clot. So the vessel. So this is now in that artery with this clot, the ugly-looking, globular-looking thing, which is just being sucked into that hose, literally sucked into that hose like a vacuum in your house, So, and then the blood flow is restored. They have fancy ways of preventing debris from, launching in the wrong direction. All the suction is pulling blood out of the brain temporarily to suck the clot in. So, it's a very, very nice way to remove a clot. So that's quite cool. So I had to put this in there. For those of you wondering, Penumbra is a public company. I am not an investment advisor. To me, it is richly valued at a PE ratio of 333, and it's a fairly small company, and it's done very well. So again, I'm not an investment advisor, but I knew more than one person out there was wondering, is that a publicly traded company or not? On to the back to the medicine. So this patient, actually, we did show that he did have a stroke, right? So that procedure worked very well. The blood flow was restored, and what we see here on his scan in follow-up is that it looks like there was the core stroke that was there when he came in, but we think that he was saved from a larger event, and he actually did very, very well. I'm going to skip over this in the interest of time, but we did have to get a little bit creative with where to go with him from that point. You've heard of medications like Xarelto and Eliquis, so there are ways of using these medications other than for atrial fibrillation, and so he's on a little bit of Xarelto along with aspirin as a dual way. I mentioned before he was having a series of just TIAs that we couldn't really get to stop, so he's done well with some creative medications. So here's a case that also illustrates how we treat stroke or evaluate stroke. This is a person who came in too late. So she had a fall, and by the time she came in, her scan looked like this. There was a clear area of shadow here, and it had caused some seepage of blood into that area. So she had an ischemic stroke with hemorrhagic complication, with hemorrhagic transformation. So this is how she came in. But this isn't a part of the brain that, she didn't have much of an obvious deficit, believe it or not. So there's parts of the brain like the frontal lobe in the right side where, it contributes to our personalities and our problem solving and things like that, but there can be parts of the brain that don't actually do much, frankly. So she looked okay, except she couldn't see on the left side. And so I say to the residents and the doctors, does this stroke explain the fact that she can't see on the left side? No, it doesn't. So something else was going on. So we had to get the MRI scan. The MRI scan confirmed what was going on before. It was actually fading out already because it had been going on for a while. But we saw on a scan that shows older things, an old scar, that actually she had another stroke that she never knew about that was in the back of the brain, in the right occipital area of the brain where vision is handled. So she had a visual deficit that she never recognized, and we found it by examining her in the hospital. And so we start to thinking, well, there's a stroke in the anterior circulation from the carotids. There's a stroke now in the posterior circulation, in the vertebral arteries. What's going on? Where does that lead you to think about? The heart, right? So if the carotid artery is diseased by cholesterol, it can only go to the carotid artery. It can't go to the back of the brain. But if there's something in the back, something in the front, we start to think about things lower down. So she was monitored for long enough that we eventually did catch that she had atrial fibrillation. So it's called paroxysmal atrial fibrillation when it comes and goes and you don't always see it right away. So when people have a stroke, we often will monitor them while they're in the hospital. If they don't show up with atrial fibrillation in the hospital and we still don't know why the stroke happened, we'll often then arrange for what's called a 30-day event monitor and have them do an event monitor for a period of time and try to catch AFib, in which case we say, there you go, that's why you had the stroke, now we know how to treat you. It's an anticoagulant, like in the old days Coumadin, or now these days Eliquis or Xarelto or Pradaxa or one of those. So it just like sort of clarifies everything very, very well when we can show atrial fibrillation. Not that we want people to have that, but at least it gives us the answers. And so that was her condition. Atrial fibrillation, just to delve into that a little bit, becomes very, very prevalent with age. I'm sure many of you know people with atrial fibrillation, and it's really very, very, very common. We have to decide most times, at least in my world, I'm usually seeing people who have had a stroke. And so if you've had a stroke and you have atrial fibrillation, statistically, your risk of another stroke is fairly high. So you buy yourself the risk of an anticoagulant. You're gonna go beyond aspirin and you're gonna go to a blood thinner. You're gonna go to an anticoagulant. These days it's usually apixaban, which is Eliquis. That's the most common one I think that's out there. There's also rivaroxaban, which is Xarelto. Those two get the most play. But in Dr. Altbaum's world, he would often diagnose atrial fibrillation. And then, it could be a discussion about whether it was worth the risk of a stronger blood thinner versus maybe taking aspirin or in some cases even nothing. So we do that by this scoring system that you add up issues like, do you have other heart problems? Do you have high blood pressure? How old are you, male or female? And do you have diabetes? And the more points you get, the higher your yearly risk of stroke goes from atrial fibrillation. So the risk of stroke from AFib can go anywhere from very small to nothing to 1.5% or so, up to about 15% a year, with all of these risk factors stacking on. So usually once you get to a score of about 2, which you already get when you have a stroke or TIA. So all of my patients have a score of 2 when they walk in the door, so they're mostly eligible for being on a blood thinner, even if they're younger or don't have any of these other factors. So, but this is how we sort of try to first do no harm, right, in our world. We want to know, is what we're going to do worth the risk of having bleeding or something like that happening? And that's how we approach atrial fibrillation. This is just interesting. So the apixaban or the Eliquis, all of these had to be compared with the gold standard going back years ago, Coumadin or warfarin, which was used, and people had to go in all the time for their INR check and make sure that it was between 2 and 3, and it was very, very difficult to avoid vitamin K foods and things like that. So now we have these other meds. These are just graphs that show in the big trials that were done with this drug that it nearly matched warfarin, but it was a lot safer. So this is like how many people had a stroke on warfarin versus apixaban as time went by, and how many people had bleeding on either of these treatments as time went by. And the newer medicines just beat out the old warfarin, pretty soundly. So that's why we're using that now. Even though it's more expensive and such, it's number one, more convenient, and it's just better. It's safer and it's more effective than the older stuff. Now, just to look at other causes of stroke briefly, so people can have carotid disease. We don't see it as much as we used to. Carotid disease was really a disease of aging and traditional risk factors plus smoking. Smoking really seemed to promote carotid disease. So when we do see it, in some cases, it requires an intervention, either an endarterectomy, which is where the doctor opens up the vessel and scoops out the carotid plaque, the clump of cholesterol tissue, or in these days also a stent can be put into that area, similar to a stent in the coronary arteries, to keep that vessel open and flowing. And the data we have is quite old, but the take-home message is that these days our medical management for carotid disease is so good because we're using medicines like aspirin and clopidogrel, Plavix, we're using high-intensity statin medications that really limit the growth of cholesterol and stabilize plaque, medicines like atorvastatin, Lipitor, or rosuvastatin, Crestor. We really push down cholesterol a lot so that when the studies were done on carotid arteries to show, should you have surgery or should you not, in those days, we didn't have all of these technologies. We didn't have ACE inhibitors and angiotensin receptor blockers and all of the great medicines that we have now to lower the risk of stroke. But still, if a carotid artery has fired off a symptom, a TIA or something like that, and we catch it, then it is often an indication to do something to prevent that. And I'm nearing a close here. So all of this great technology, and I was starting to talk about these simple medications. We can do suction thrombectomies, we can do mechanical thrombectomies, we can do IV TPA, we can do CT perfusions, we can do all this great stuff. But to be honest, when I see people in the office who have had a stroke, we may or may not have atrial fibrillation to deal with. That's very common. But sometimes they've just had a stroke and we just don't know why. We don't know exactly why. We presume there's some cholesterol somewhere in the circulation. We just haven't shown it on a scan. But we have, I meant to go to this next slide. I meant to fully load in the next slide. Whoops, hang on, back up. Okay, I see this is loading gradually. It's to build tension. But this was a great study that I really liked, and it sort of boils it down. I tell a lot of people there's a triple play to go for after a stroke. Number one, by default, you need to be on something that keeps blood flowing. It's usually an antiplatelet. That could be aspirin. It could be aspirin plus clopidogrel or a Plavix temporarily, and then aspirin or clopidogrel. That usually is what we're talking about, an antiplatelet medication, number one. Number two, a cholesterol medication, a statin medication. I know there's controversy about the statins, but all the studies really show that statins are great. Being on a statin medication is very important. We like to, after a stroke, we take our targets. So someone who in primary care may have an LDL target of 100 or 130 or something like that, we then readjust our targets down. So the target goes down below 70. So if you can be on aspirin or Plavix, be on a statin to get your cholesterol down below 70, and you can keep your blood pressure under control, you can take 3 pills, right? An aspirin or a Plavix, a statin, and a blood pressure medication. This study shows that over 2 years, you can shrink your risk of recurrent stroke from 16% to 7%. So this was not like a super high level study. It wasn't a randomized placebo-controlled study, it was an observational study, but it was really to kind of just drive home this point, that these simple things that we do that are all at this point cheap, and no one's making any money on clopidogrel or aspirin or atorvastatin or whatever, it's cheap stuff now, it has a big impact in the recurrence rates of stroke. And so I like to drive that home when I see people in the office and say, stay on those 3 simple pills, right? So again, these are our key targets: blood pressure below 130 over 80 after stroke, and LDL cholesterol below 70. So that's the bulk of what I wanted to say. I think we all kind of recognize risk factors. There's risk factors that are not modifiable, like what age we are, what gender we are, what our heredity is like. There's these risk factors that we all recognize: heart disease, blood pressure, and such. Smoking, heavy alcohol use, and physical inactivity are lifestyle behaviors that can increase the risk of stroke. I think I already mentioned a lot of this. It's the medications, it's the 3 medicines in most cases: regular exercise, avoiding obesity, the Mediterranean style diet keeps coming back in all the research as being the most effective way of, the most effective diet really for vascular disease. And these are the basic symptoms of stroke, but I like to boil it down to say if your body is suddenly malfunctioning in some way or something's not working suddenly, it could be a stroke. So the best thing to do is call 911. It's not really a good idea to get in the car, especially not drive the car. It's not even a good idea to have someone else drive you, because then you have to wait in line and go talk to triage and wait for the nurse to notice you and all this. If you go in by ambulance, you get a straight shot to the CAT scan, literally. And that's the way to go if you're having a stroke, because remember, we've got 45 minutes to treat you. And that's it. Thank you. I hope that was the right timing. Was that the right timing? Yeah. Okay.
Well, that's scary. I'm glad I went out for, glad I went out for a cigarette and a drink. Oh, sorry. Anyhow, just to lighten the mood. So my friend John Brandt is over there in front of the big white curtain. If you have a question for either one of our incredible physicians, if you would please make your way over and go for it.
Hi, I have a question. If you've had a stroke, you were on Coumadin, then you were on a full aspirin, then you were on a baby aspirin. Can you be on a baby aspirin for the rest of your life?
You know, when we start medicines like aspirin, you know, for a vascular condition, we kind of expect it to be fairly indefinite. Aspirin is quite safe and very effective for coronary disease, for cerebrovascular disease. So unless there becomes an issue, bleeding or stomach problems or, you know, issues with that medication, usually we're not looking back. You know, once someone has had a stroke, unless it was something very, very particular that happened to a very, very young person, like an injury to an artery from an accident, usually we're advising people to stay on antiplatelet medications like aspirin indefinitely.
Forever.
Yeah.
Thank you very much.
One quick thing to just clarify there, because there's a lot of controversy about aspirin. You read about it, people used to recommend everybody take it, then they said not everybody should take it. Basically, aspirin there's two ways of using aspirin. Preventatively, which we call primary prevention. You've never had a stroke, you've never had a heart attack, you don't have angina, you don't have any major symptoms. And then secondarily, meaning you've had a problem. If it's primary, right now, the general recommendation for most people, certainly over 60, is to not take aspirin. Don't take it preventatively if you've never had a problem. Flipping that around, ironically, if you've had a problem, like a stroke, you should be on it the rest of your life. It sounds binary. It's not as binary as that, but you should definitely stay with aspirin indefinitely.
Hi, you mentioned earlier that people with some metal in their bodies can't have an MRI, so would that mean that people who have had hip replacements, for example, can't have an MRI?
No, you know, most modern medical grade metal implants are okay.
Okay.
So a hip replacement, a knee replacement is okay. Stents after a certain amount of wait time is generally okay. So stents in the coronary arteries or stents in other places. But there's like a stent that's from 20 or 30 years ago, we may not be able to clear. Older pacemakers, so newer pacemakers can go in with some prep and some, you know, follow up to reprogram it and such. But that's not a totally blanket statement. But if someone has had an injury that have some unknown metal in their body, I mean, that's pretty much a no-go because we don't know if that metal would react with the magnet that gets the image. So
Okay.
there's a lot of protocols about that.
Thank you.
Yeah.
Other questions?
We answered all the questions, wow.
While people are thinking of their question, Dr. Story, when do we come see you?
Yeah.
Well, you can come anytime you like, you know. I see people for stroke and all sorts of things. I hope you don't need to see me, but you know, I used to do a lot of my work in the hospital. I was on call for, you know, a large part of the time at Norwalk Hospital for many years. So I would see you in the emergency department or up on 7 West or the ICU or something like that. We have dedicated neurohospitalists now that take that from us, thankfully. They're people who just want to be in the hospital. They do that work, and I'm mostly in the office now. So my world in stroke now, I get calls sometimes for advice about things in the hospital, but we have very, very good people in the hospital. But I mostly see people after they're coming out of the hospital after their stroke. So I might see them a few weeks later and go over, how's your blood pressure? How's your cholesterol? You know, have we done this event monitor? Do we know why you had the stroke? Are you taking your aspirin, your statin, and your ACE inhibitor, or your diuretic, or whatever? So that's the time that I mostly get involved in people after they've had a stroke.
Is there a preventive aspect to neurology?
A preventive aspect?
Coming to see you before something happens?
Not usually. That's
I'm not sure of the question, John. Obviously, if a person has hypertension, the best thing you can do to prevent a stroke is treat their hypertension. If they're a smoker, get them to stop smoking. There are guidelines for cholesterol and obviously lowering cholesterol. Treating risk factors is dramatically effective in lowering risk of atherosclerosis. So we're seeing actually less coronary artery disease. I think we're seeing less strokes too. Yeah. At least in younger people, the age is moving up because obviously age is also a risk factor. But there's a lot preventatively done, but it's all based on risk factor management.
I mean, obviously, I see people who I recognize they're seeing me for something else, maybe neuropathy or headaches or something like that, and I may recognize that they're at risk for stroke, and we'll have that discussion. And you know, but usually we let the excellent primary care and internal medicine colleagues handle a lot of the preventive aspects.
We have a new contestant.
Yeah. Hello, I'm here because I want to learn more for my father's sake. He is a retired anesthesiologist. In May 2019, he started having numbness in his arm. Even though my mother begged him, she's also a retired anesthesiologist, to go to the hospital, he didn't go. For 2 days. He went in, and luckily it was, as my mother wrote in an email, small infarcts of the parietal and subparietal lobe, because she's clinical that way. And I'm like, so these are mini strokes, right, Mom? And I know that his father had that too, lived until 92, but had those symptoms. October of last year, he was having symptoms again. My mother insisted he go to the hospital. They went. He signed himself out AMA, against medical advice, because he did not want to wait for the neurologist.
It sounds like a doctor.
So much. Yeah. Very luckily, he ended up in the ER that night. What you said about driving themselves, we literally got a call from my mom saying, your dad can't get out of the car. He'd driven himself home from the hospital, but now couldn't get out. What do we do? It's like, call 911. They called a friend to drive him to the hospital. He ended up in the ER. 6 weeks in rehab. He's home in Florida, and he's actually doing remarkably well. But how do I manage that? That is my question. And when he got, as he was recovering, he told the neurologist that he took himself off the Plavix that he was on because he was worried about bleeding if he needed any kind of issue. This is not a medical question. This is a parental question. What do I do?
Wow.
Yeah.
That is tough. Yeah. You know, I think, unfortunately, people eventually learn a lesson, I think, if they're not taking certain symptoms seriously. I mean, I think, you know, I think there's a lot of denial in neurologic symptoms. You know, oh, I just slept wrong. Oh, I'm just tired. That's why I can't talk properly. Or, oh, there must be something in my eye because I can't see properly. And, you know, there's a tendency to kind of sleep it off because it doesn't hurt, right? But when people get chest pain, they're a little more willing to go in and get that seen about. And I would say if a neurologic symptom is on par, at least with chest pain. You know, chest pain could be you're about to have an MI, right? And I think we all know culturally that's a big bad problem. I think we just have to keep the messaging that even mild symptoms can be the beginning of something that could turn into something more. I don't know. That's a tough one. Yeah, I think it's a messaging thing that neurologists have always...
As you said, it's not a medical question.
No.
It's a sociologic and perhaps a psychological issue. And with that degree of denial, and your father knows better, he's an anesthesiologist, realistically, I would actually refer him to a mental health worker.
We have another question.
I have a question. There was an article in the New York Times a couple of weeks ago that really attracted my attention because I'm about 15 pounds overweight. And the article said, obesity treatment relieves heart failure symptoms. If you're obese, you shouldn't be, right?
Yeah, I didn't see that particular article, but I know what's going on. These
This is Wegovy?
Yeah, it's one of the Ozempic type
Was this,
medications.
I think it was a Wegovy article. Mm-hmm. And Wegovy, I don't know if it talked about stroke. I know it talked about what they call MACE, which are myocardial serious diseases. And basically, it lowered the risk 20%. So I think obesity, this was only related to obesity, though, not for people who are normal weight. But definitely obesity is linked to coronary disease, stroke, and Wegovy and all these new medications that help us lose weight remarkably efficiently are going to pay tremendous dividends in terms of getting it, and probably will pay dividends in getting it approved by Medicare and insurances, because it's no longer what they consider vanity. It'll be a matter of medical management and medical health.
Right, I think this is going to be a huge thing, and it's obstructive sleep apnea, could possibly be, in many cases, cured with weight loss, diabetes. It's going to impact a lot of human health, these medications that may be able to result in meaningful weight loss. And then, with all of these issues, high blood pressure also impacts stroke as well. But we shall see.
Yes?
Hi, thank you. Yep, I got it. What is a stroke center, and what is it? Does it offer something that going to the hospital doesn't?
Oh, sure, yeah. So a stroke center is certified by the Joint Commission. The Joint Commission is a national independent body that certifies centers of excellence in a variety of topics. They also certify other disease processes. But basically, you have to demonstrate that you're following all of the peer-reviewed guidelines coming out of the American Heart Association. You have to make sure that you have adequate staffing at that hospital, you have adequate training at that hospital, you have adequate outcomes, that when you monitor the charts and you do chart reviews, that all of those patients were getting TPA if they needed it. All of those patients were getting aspirin if they needed it. We're getting prevention for leg clots. We're getting prevention for all of the complications of stroke. And then they look at basically your outcomes. And we get visitation every 2 years from the Joint Commission. They stay for 2 days and they grill us. We have to present to them. We have to show them our data, and they certify us. Norwalk Hospital has been a primary stroke center since 2006, I believe.
And not a lot of, there are many hospitals throughout the United States that don't have the imaging, the MRI sophistication. They don't have a neurosurgeon on call and an entire team that can come in and act immediately. As I said, it's time is brain. You have to act quickly. You go to some areas of Maine, of Idaho. I mean, Sun Valley might have a wonderful hospital, but it doesn't have a stroke center, I suspect. And the reason is they don't have the doctors and they don't have the technology to do it. So a stroke center, if I'm having a stroke, I would definitely want to be in a stroke center, not because it's unique. It's simply because it has everything you need and you have options. If you go to a smaller hospital, they probably have TPA, they can probably do a clot buster, but if you come in there in 5 hours, they can't touch you. And basically, you still may have a lot of salvageable tissue that if you had a stroke center, could be saved.
Right, in a lot of part of the country, you may go to a non-stroke center, you may phone in or do a teleconsult with a stroke center, maybe get TPA, and then get into a helicopter or an ambulance and go to a stroke center for the rest of your care. So,
lots of lost time.
Thankfully, we're full of stroke centers all over the area, including us in Norwalk and all of our local hospitals.
I'd like the audience to know that I get commission for the number of questions you ask. So, does anyone have any more questions?
Okay, I think class
On
is
the way.
just about over. So, on the way over? Okay, ooh, another contestant.
We have another question in the front row also.
Yep.
Okay.
Hello?
Hi there.
I'm interested in the AFib aspect of it because I've had AFib episodes in my early 40s, but I could feel them. And I was able to run down the cause. It was basically high dosage caffeine with alcohol. But I know other people who have had AFib who have no idea they have it until they get secondary symptoms.
Right.
Is there any treatment for AFib other than ablation or something like that?
The main first off treatment for AFib is to make sure it doesn't cause us, well, first make sure it's not going too fast and making someone dizzy or fainting or something like that. And so that can be treated with medications that control the rate when someone is in AFib. But in my world, it's really making sure it doesn't cause a stroke. So the first thing is to be on the appropriate blood thinning medication, usually something like an anticoagulant. Bob can maybe talk about some of the others.
If you are truly asymptomatic, and you have no symptoms and you have no congestive heart failure, and your pulse rate, let's say, is 80, but it's irregular, the only true danger is stroke and some cerebrovascular components. There's been risks of dementia and other issues, so you have to take a blood thinner. However, if you have any other symptoms or you are symptomatic or you have heart failure, there's lots of medications. There's things to slow the heart rate down, like digitalis, I'm sure you've heard of, beta blockers, calcium blockers. There are antiarrhythmics, which we actually don't like to use as much because in head-to-head trials, ablation is just better. But if you're truly asymptomatic, and then the only thing you would need is you would follow the CHADS VASC score, predict your risk of stroke, and if you have a CHADS VASC score greater than 2 or equal to 2, you need to be on lifelong anticoagulation.
In my
And not
case-
having symptoms does not decrease the risk.
In my case, once I figured out what was causing it, it's been 30 years since I had an episode, so. But I was just curious about the clinical aspect of AFib. If there's long-term damage from it or
Well, what was causing your atrial fib? I'm sorry?
caffeine, high dosage of caffeine.
Well,
unexpected.
I don't mean to disagree. You're probably absolutely right. But ironically, there was a big study that just showed caffeine did not significantly increase the risk of atrial fib. One thing I would do if I were you, if you haven't been, is just to be monitored for a period of time, because asymptomatic atrial fibrillation is pretty common. And it, again, does put you at risk for stroke. So if you don't feel it, it doesn't mean you're not having it. One way to absolutely confirm that is you can either use a 30-day monitor or there's even a 1-year monitor. They slip it right under the breastplate. It's painless, takes a second, and it monitors you for a whole year. It's called a reveal. And that is really the best way to know that you are absolutely atrial fib free.
Okay. Thank you.
I think we have a question in the front row here, sir. That's all right.
The mic can come to you. You want to just stay right there? I get extra for this.
Let's hear it for John. All right, give it up for John. Thank you very much.
Hey, so, has the cooperation between the regulatory authorities and the practitioners yielded, or let me not put an answer in anybody's mouth, but what has it yielded? Making sense?
So like the Joint Commission, for example, that comes in and the state, you know, it keeps us honest, really. I mean, we have to prepare. We prepare for weeks for the Joint Commission to come. We get our data together. We look at things we might, you know, not take a notion to look at. We set aside a lot of time to prep, and we find things and we fix them and we get it ready. We're not like we're not doing this anyway, but it keeps us honest. And you know, if you're certified by the Joint Commission, it's good for your hospital. It gives confidence, you know, that you've been looked at by an outside body that has come in independently and looked at you and made sure you're doing all the right things. So we don't look at it as sort of adversarial. You know, they're usually nice people, but they're harsh, they're tough. They always find something. And they make us better. We say, really, you care about this? Okay, let's fix it. And then weeks later, we say, I'm glad we fixed that.
Good to know. Okay, I think it's late enough. I think it's time for us all to go back out in the heat. I'd like to remind you that our second session on headaches will be held Monday, October 30th at 7 p.m. And our third and final session on dementia will be held on Tuesday, November 21st, also at 7 p.m. Please, let's give it up for Dr. Story and Dr. Altbaum. It's a wonderful turnout tonight. Really, really inspiring. Thanks so much. Good night.